Hey everyone, Woodruff here. So I put together a PowerPoint just kind of all about labs. I know that this can come up a lot, especially when you're new in nursing and you're just like, man, what do these labs mean? How do I know what labs that I want ordered? What is it really telling me about my patient? And I'm here to start out by saying, one, I'm not a lab expert, and a lot of this depends on facility, physician, and you're going to hear people say differently, but I'm going to give you, based on I've found, common labs, and then I will preface this, which I went in textbooks and or via Google and kind of looked around and found different lab values. So you may find very different values depending on if it's using a different scale or what facility you're at. So please don't come at me with, oh my goodness, you're completely wrong. I mean, if there's something that's completely wrong, please point it out because it's always possible that I mistype something. I made this a long time ago and have not. I looked at it, before I started this video, obviously, but it's possible that I have something that's a little mixed up. So feel free to correct if there is something completely wrong, but just know there is some finesse and some differences. And you can put a couple physicians in a room and they may all disagree about what normal is for something. And then also some physicians might say, I'm worried about this, whereas another one's like, oh, that doesn't really worry me. So there's also just experience and preference. But to get started, let's talk about labs in general. So the labs, of course, are tests that can help paint a picture of what is going on within your patient. Keep in mind, they're not always 100% accurate. And what I mean by that is that it depends on if they were drawn accurately, because there's things like hemolysis or if you didn't waste enough. Because generally, when you draw labs, what you're doing is you are let's say that you're going to draw directly from the patient. Obviously, you want to make sure that you're not drawing from a vein that has fluids or something going in very closely, or some other medication, et cetera, right there. And then let's say you're going to draw labs from an IV or a line, then you have to make sure you flush accurately, draw back enough, etc. So just know things can also go wrong. Machines and tests are not always right. So if you get a lab result back and you're like, this just does not match what I'm seeing in my patient, it's always okay to do a redraw. Just talk to your doctor. Yeah, and pretty much you always need to look at how does this look based on the patient's position. So for example, if I draw a patient's blood level and it says their hemoglobin's 2, and I'm looking at them and they're up walking around talking to me, it's very unlikely that their hemoglobin is 2 and they're walking around and talking to me. So it's important to know labs because you want to know what labs to ask for based on different patient situation, or if you're looking at your orders and you're like, hey, what labs do I need? Like it's important to kind of know as a nurse to clinically be able to evaluate what labs are appropriate or not appropriate for a patient. You also want to know what labs tell you because you can look at the numbers, but if you don't really know what the numbers mean or how they correlate for you, then it can be difficult. And then, also what actions to take. What labs do you need to call a doctor about versus what labs are, maybe expected or routine. And this can really vary, of course, on the patient because, sometimes for some patients, it's like, okay, I work with patients that have car accidents. Some of their numbers are going to be abnormal or high, and that's expected, like their white blood cells or other things. But when do I need to take action, or when is it a time to call the doctor or to need to take some, emergent action because there's something serious going on? But if you take nothing else away from this video, keep in mind labs are one part of a much bigger picture, and you can't just look at one number and know exactly what needs to be done for a patient. You have to bring everything together: the patient's history, their current condition, their vitals, their physical assessment, other things all together, versus, hey, this number is going to tell me everything that I need to know about the patient. For example, for that, sometimes a number can be abnormal, but it's more about how the patient is responding. We see this all the time, for example, with CT scans. I work, in trauma, and there's patients that have really abnormal CT scans, but they're sitting there talking to me and responding appropriately, and that's a better sign of how they're doing than a scan. And same with a lab. Even if a lab seems very off, if it's not always necessarily correlating with their clinical picture, it may not be as scary or as overwhelming as it might seem. And again, normal results are going to vary. So as I'm going in, again, please don't come at me. I swear I did my best to do my research and try to do these, but I'm human. I can make errors. So focus less on the numbers here versus like the general, like kind of where are we looking for and what do they mean? So, common labs that we get on a daily basis for most patients are going to be things like a CBC or complete blood count, and we're going to go deeper into each of these. A BMP or CMP, also known as a chemistry. So, if they say, "Hey, I just want to get a CBC chemistry," this is what they're talking about. You also can hear a BMP or a CMP called like a Chem 7 or Chem 8. Um, those are the difference between a BMP and a CMP. And the main difference is there a BMP has a little, like a CMP has a few extra labs in it that a basic does not have. Electrolytes like magnesium or phosphorus, and then maybe coagulation studies, things like that are more daily labs. And then some other common ones that you might see done are things like thyroid labs, like your TSH or T3 or T4, your infection labs, such as like a procalcitonin, inflammation labs, cardiac labs. Here's some examples. Metabolism labs like a hemoglobin A1C, and then a urinalysis or blood cultures. Those are some other examples. But let's kind of go through and go deeper into some of these. So starting with the CBC, there's lots of parts to this test, and I'm not going to go over all the parts because there's a lot of stuff that I'll be honest that I don't understand. But the most important ones to focus on that you're going to look at when you're looking at this test is the white blood cell count, which is usually the normal is like 5 to 10,000. And this is obviously going to tell you about infection or inflammation, kind of have there at the bottom. Your white blood count can go up for a lot of reasons. And sometimes it's what we call reactive, where your body is responding to an inflammatory or other process. Because remember, your white blood cells are your like fighters. They're the ones that are coming in. And if there's an infection or some sort of threat against your body, they increase to like go on guard, like, to protect you. And so keep in mind with the white blood cell count, it can be elevated. We kind of just watch trends. The second a white blood cell count goes up doesn't mean your patient has an infection. So it's just about kind of watching and seeing about possible causes. If it continues to stay up and they're having fevers and other things, they might order some cultures, and then that would give them a better idea of if there's an actual infection, and that's when antibiotics and stuff would be ordered. But keep in mind, any stress on the body, certain medications like steroids can also increase your white blood cell count. So it does depend on the patient. Then another one that we check regularly is what's known as the hemoglobin. A lot of people are like, oh, what about red blood cells? We don't really look at red blood cells often for most patients. There's the blood disorder patients and other things. That's a whole other whole other story. But generally, we look at hemoglobin. And when we're looking at hemoglobin, it varies by gender, but normal is like 12 to 16. But I'm here to tell you, most people in the hospitals, hemoglobin is not bigger than 10, and that's okay. We only like hemoglobin, I'm only really concerned about it if it's getting in the like less than 7 territory. Some patients, I'm going to be concerned if it's less than 8 for them, and that's okay. So I always want to kind of know what my goal is for that patient. Some patients we want to keep a little bit higher, but usually until it's getting like 7 to 8, we're not that concerned about it. For 1 second, my cat opened my door. Sorry about that. And my son's watching TV, so I don't want you to get distracted. So yeah, anyway, so with the hemoglobin, we're like I said, we're only really worried when it gets less than 7. Most hospitals or research kind of guides that we transfuse for a hemoglobin less than 7. So if you call a doctor and you're like, oh my God, my hemoglobin's 10, they're not going to be too impressed. The other thing you want, they're going to be like, why are you calling me? But we want to keep in mind, though, is that it's also about trends, too. If my hemoglobin was 12 and went down to 7, might be something I want to report. Now, sometimes hemoglobin can go down quickly if we give a patient a lot of fluids because it's like dilutes all of the hemoglobin. And just to remind you, hemoglobin is like the oxygen carrying component to the red blood cell. So it's like how much, I always think of it as like how much oxygen can I carry around my body. So again, it can be lower, but once we get less than 7, that's usually when people are going to start to experience symptoms. They can have lower blood pressure, they can have trouble oxygenating, trouble breathing, etc. Um, Oh, and I guess I forgot too with going real quick back to white blood cells because I'm kind of going back and forth between the top and the bottom part of the slide. We worry about high white blood cells for infection inflammation. If it's very low, we have what's called neutropenia, where there's really high risk for infections. In other words, if I don't have a lot of white blood cells, then I'm really high risk for having like being at risk for not having enough, white blood cells to defend against an attack on my body. And that's where we might put them in neutropenic isolation. So yeah, so then getting back to hemoglobin, we don't really worry if our hemoglobin's high. It's not something that really happens often. I've never heard someone say, "Oh my God, quick, get the doctor, the hemoglobin's high." But again, we worry more if it's low. Then there's platelets. So platelets, they can be elevated at times if you had like your spleen taken out, things like that. You can have high platelets. We don't really worry about high platelets ever. But for unless it's like new and random and for no like there's no apparent reason, that's more of like a weird disorder thing versus a common thing. The thing we do worry about is when platelets get low. When platelets get low, often it's a sign that the patient needs to get a platelet transfusion. Now, when I say low, it really varies. It depends on the patient. If it's a liver patient, we might not give any platelets until their platelet count is like below 20,000. But other people, if they're in 50 or 60,000 platelets, then that's like, a pretty huge drop for them. We're going to be checking into that. The other thing that we want to consider is with platelets is that if the patient's on heparin, I don't know if you guys remember this, my painful cardiac lectures, but there's what's known as HIT or heparin-induced thrombocytopenia. And when a person's platelet count gets low suddenly, especially if it's like dropping steadily each day, after starting heparin, we worry that they might be having an immune response to the heparin, almost like an allergic reaction. And it's like it can cause low platelets. So it's something to kind of keep an eye on. If you're watching your patient's platelets and they're going down by pretty huge chunks each day, you might want to report that to your doctor. Um, then, and the only treatment for low platelets is to, of course, if there's something that's making their platelets go low, like the heparin-induced thrombocytopenia, we want to stop the heparin and change it to something else. But most of the time, people's platelets are getting low because they have a clotting problem, they're bleeding or losing blood, or have some sort of clotting disorder. Or they have liver problems. So we kind of want to keep an eye on that. And the only real treatment for that is to replace the platelets as the doctor sees fit. And last but not least, the one other one I'll look at sometimes, and you're not always going to see it on every white blood cell count, or sorry, not the every CBC, but it's what's called bands. Bands are, I think, called bands are babies. They are baby white blood cells. So when your body is making has a massive infection or a lot of infection going on, it's going to start making more and more of cells that it needs because it's like, oh man, I'm running low on soldiers. I need more. So bands are your baby soldiers for fighting infection. So if my bands are high, it's usually a sign of an acute infection. So something we can look at. So then moving on to the chemistry or the basic or complete metabolic panel. So on these, usually one of the first things that I look at are my electrolytes. So I look at my electrolytes, usually my potassium and sodium are going to be two of the major ones. I do look at calcium too, but I'll tell you sometimes the calcium on a chemistry like this can be not as accurate unless it's like very severe. Usually what we want to get is what's called an ionized calcium, and we can get that on like a blood gas and things like that too. Potassium, it's usually like I always remembered 3.5 to 5 is about what's normal. We don't like a potassium that's too low because your heart can stop, and we don't like a potassium that's too high because your heart can stop. You can have like if you're having a whole lot of PVCs or abnormal heartbeats, it can be sign of potassium abnormality. So you can sound really smart if your patient's having a lot of ectopy and it's new and different and be like, let's check a chemistry and sound really cool. That's one thing to consider with calcium. Calcium can be really high oh, and sorry, real quick for potassium, if it's low, we replace the potassium. If it's high, there's hyperkalemia treatments we can give. And there's a variety of them. Most of the time, we do a combination. It's what we call redneck dialysis. At least that's what we call it here in Texas. And so it's a mix of insulin, D50, and then we give a little bit of calcium to stabilize the heart to start out. But pretty much where insulin pushes the potassium into the cell. And what do you call it? Then we give D50 because we're giving a bunch of insulin and we don't want the patient. And we give, by the way, we're giving the insulin intravenously, not subcutaneously. Then we give the D50s to counteract their blood sugar from going too low. And then the calcium we give before that is just to stabilize their heart because the rapid pushing of insulin can cause heart or cardiac instability. Um, especially for someone who's not diabetic and things like that. So we do that. Sometimes there's other treatments we can do too. There's stuff that we can stick up the butt and like that helps. It's called Kayexalate. And we can give it like an enema. And you lose a lot of potassium when you poop. So if you have someone who's having a lot of diarrhea, they can have a low potassium. So what we do when it's high is that then we kind of give this enema or force them to poop, and that can help to get some of that excess potassium out. And then there's some other treatments that we can give orally to help get potassium down. For replacing potassium, if it's really low, we usually like to do a mix of oral and IV. I know everyone's like, oh my goodness, I just need IV, but I'll tell you, it's not always well absorbed IV. So usually a mix of oral and IV is helpful to kind of get it up depending on how low it is. And just as a warning, patients hate to have their potassium replaced because they are literally like horse pills, huge pills you have to take for your potassium when it needs to be replaced. So people definitely are not a big fan. Um, and I don't know if that's true. We usually, if we have a patient who has like a feeding tube and stuff like that, we usually like to get a powder substance. I have a feeling, and I could be lying about this, but that you can't crush normal potassium and put it down the tube. I think it's because it's too thick and it clogs the tube. So usually we get this, there's like a potassium powder that we put down there if they have like a feeding tube. So moving on to calcium, calcium can be low or high. If it's low, obviously we're going to replace it. Calcium can also lead to cardiac instability or abnormalities, but it also has a lot to do with, your bone metabolism and stuff like that as well. It can be low because of nutrient, like your people are not getting it in, they're not getting good nutrients. Then the most of the time when calcium is high, this should be your like ding, ding, ding. The patient may have cancer because a lot of time in malignancy, especially if there's some sort of bone malignancy, their calcium or they can have hypercalcemia. It's a side effect of cancer and then also a sign of cancer as well. It's a side effect of cancer treatment sometimes and also a sign of cancer. Yeah, if someone's calcium is super high, I'm talking about like 14 to 16, it's usually a sign that they've got a problem. And usually to get calcium lower, we do stuff like IV fluids, we give diuretics like Lasix to help get it down. And then there's some specific targeted meds that we can give. I'm not going to get into all those because I don't want to overwhelm you. But yeah, that's what we do for calcium. For sodium, sodium has to do like when I think sodium, I think about your like neurological or brain status. So if sodium get and usually I know this is whatever the book said, but I usually think 135 to 145. Um, and so, what you want to consider with sodium is that if it's too high, um, then it can lead to it's just like think of like it's all about like where water is, and if my sodium gets off, it can change mental status. So when I think of sodium, I think of mental changes. It's a lot scarier if your sodium gets too low than too high. But if my sodium gets too high, and this can get high, we see it often in patients that do have like fluid imbalances or issues, nutritional problems. But the big one you're going to see, especially if you work in like an ICU, is sodium can get high for patients that have tube feeds because they have a lot of sodium in them as a preservative. So we see their sodium get really high. And so what we do to get sodium down is we give them free water through their feeding tube, or we can also put, if they can't take stuff orally, then we put them on a D5W drip. And I know it seems like, why are we giving them sugar water? But D5W actually goes into your body like free water. So it just kind of flushes to get that sodium down. Um, for low sodiums. This is scary. This is the one that like I'm sure in one of my other videos I talked about it, but when your sodium gets low, you get cuckoo. Years ago at my hospital, I had this patient that was found at McDonald's literally rubbing sauces. I'm talking about like the McDonald's sauces all over their body. And they were like, they just thought they were like a psych patient, but turns out the only problem with them was their sodium was low. Maybe they were trying to get like all the saltiness from the sauces into their body, and I don't know how that was working for them, but obviously maybe not well. Um, but yeah, so their sodium was low. So what we do is we want to obviously replace it. So you might think we want to be very aggressive with this, but here's the thing: when it comes to sodium, we do want to get it back to normal quickly, but not so quickly that it can cause harm. So there's like certain amount of points that you want it to go per day, and this can vary by person, physician, and stuff like that. But when it gets low, like 115, 117, these patients are cuckoo. They can become unconscious, comatose, change in level of consciousness, and it can be very serious and cause serious brain abnormalities if you do not correct it. So we usually start out with some gentle sodium containing fluid. Sometimes we will, if it's low enough, we will put them on a 3% drip, something to try to get their sodium up. It just depends on how severe it is. And then again, how aggressive the doctor wants to be based on the patient's condition. So aside from electrolytes on the basic or complete, we also like to look at kidney function. So there's two measurements we usually look at for kidney function from a nursing standpoint. I mean, if we're getting into deep nephrology stuff, there's lots of other numbers like creatinine clearance, GFR, or the glomerular filtration rate. But as a bedside nurse, most of the ones you're going to look at are BU and creatinine. Now, I'll tell you the bun is like a hamburger bun where it complements, but it's not the most important one. We usually focus on the creatinine. But the bun, blood urea nitrogen. What this is pretty much a sign of waste products in your body building up. So when your BUN is higher, it's showing that there's waste products that your kidneys are usually supposed to get rid of, and it's not getting rid of them. That could be for many, many different reasons. You could have, and you could go to my renal videos if you want to learn about this. You can have a pre-renal cause that's causing your kidneys not to work. You can have something messing up with the function of the structure of the kidney itself, or you could have an obstruction after the kidney that's causing a problem. But as a whole, the BUN is, it's one thing that we look at. And when it's high, we kind of say you have like what's called a uremia, or there's just a whole bunch of like waste products building up. Then the creatinine. So this is the big dog that we usually look at. This is the burger in the bun, if it makes sense. I'm gonna stop being weird for at least 2 seconds. So the creatinine is more of the number that we usually go by. And the normal is like zero point 0.6 to 1.3 or 0.6 or zero point 0.7 to 1.2. I've seen all over, but it's in that range. What this tells us is the actual like amounts, like if this number is higher, that means you're holding on to creatinine, which you're supposed to get rid of in your kidneys, but if your kidneys aren't working, this number will be higher. So this is a measure of how your kidneys are doing, but I want to give a lot of caution because kidney function is all about how the kidneys function. So in other words, if you have a patient, you come in and your patient who's not like a dialysis patient or something has a creatinine of 7 and you're like, oh my God, they're about to die. The questions you need to ask yourself is what's their urine output? What's their potassium? Because the better measure of how kidneys are doing is are they peeing? Like almost the most important question you can ask is are they peeing? And if so, are they peeing enough? And then also, how are they managing their electrolytes? Because one of the first electrolytes to struggle if your kidneys are really in serious trouble and you need like dialysis is going to be the potassium. And if potassium gets high, we can have critical heart issues, so we really worry about it. So with kidney function, what you want to consider is yes, it is important to look at these numbers. If it's going up, we want to do things to try to protect the kidneys. We want to maybe give some gentle fluids if they are low on fluids. We might try a little diuretics on the patient and see how they do, but we're going to avoid drugs that can hurt the kidneys. We might change dosages of medications to adjust so that this is something you might see. So maybe your patient was on Lovenox and all of a sudden they switch to heparin and you're like, why are they switching to heparin? What's wrong? Heparin is actually a lot easier on the kidneys than Lovenox is. So a lot of times when patients' creatinines are elevated, we'll switch them to heparin versus Lovenox just because it's easier on the kidneys. But yes, but with creatinine, you just, again, Yes, if it's elevated, we're going to like do stuff like adjust medications, maybe what we call renally dose stuff or change the doses so it's not so hard on the kidneys. We're going to do whatever we can to avoid more harm to the kidneys and provide gentle recovery for them. But just know that number might take a while to get back to normal, and that's okay. It's more about how's the patient doing because sometimes we're like, oh my God, does my patient need dialysis? They only need dialysis if they are making no urine, little to no urine, or if they're having severe electrolyte imbalances that they cannot manage on their own. And also, it's up for a nephrologist to decide. But yeah, something to kind of keep in mind. So then we can also look at liver function. This is on a CMP only. And I want, what do you call it? Never mind. This is on a CMP only, so you're not going to get these on the basic. There's a variety of labs. It's the AST and ALT, which are, in the ALK Phos, all kind of related more about the liver. And then the bilirubin is more about the gallbladder and things like that too. But all of these can be, if they are high, we don't really worry if they're low, but if they are high, we worry about them being a sign that there's a problem to the liver. And there can be a lot of causes of liver problems between personal choices like alcohol use. There can be medications that can cause liver problems. There can be infections that can cause liver problems. Your liver can get just overwhelmed if you're receiving a lot of medications and things. So there's a lot of causes of liver problems, trauma, cancer, other things. So it's just kind of looking at these. Um, we kind of like with the kidney, we do things to try to protect it, like kind of be gentle or protect the liver when it's not happy. We try to avoid things that are going to cause worsening damage to the liver. But a lot of times we just kind of trend and watch these, and the liver will calm down if it's something that's reversible that we can do for it with time. And the things that like hurt the kidneys versus the liver kidneys, we worry about things like I mentioned, Lovenox. Certain antibiotics can be hard on the kidneys, and let me think what else. Like IV contrast, things like that. Whereas the liver, we're thinking things like Tylenol and things like that are usually the common things we think. A lot of the liver and kidneys are what process all your drugs and stuff like that. So if you're getting a lot of medications, there's also a lot of like infectious disease drugs and stuff that can be harmful to the liver. So usually a pharmacist can be really helpful. And if they kind of see that and they're working with a doctor, they can start to kind of look at what they can do to make it a little bit easier on the person. Other things that are going to be in your chemistry are going to be an albumin, which this is on the CMP only. And albumin, this is one that a lot of times people get kind of caught up on. Albumin is a measure of how much of albumin is a plasma protein in your blood. And obviously, measuring that is going to be measuring how much that you have. This is not the best measure of really like how your status is due, kind of like the whole like ionized calcium and regular calcium things. You have to keep in mind that like a pre-albumin tells you a lot more about how your body's functioning, but albumin effectively, it can tell you about how nutrition is going. If your albumin or pre-albumin is low, you may have a nutritional deficiency. It also can be a sign of a liver problem because when my liver's not working, I'm not making albumin because it's made in the liver. And so the one thing that I do see a lot of people do, and this is something I didn't know when I first started, is that if my albumin's low, I'm not going to call a doctor and say, hey, do you want to give albumin? And I know that's going to sound counterintuitive, but we more look at the patient's picture versus looking at this number for albumin. Albumin, going back to what it is, it's a plasma protein. And the way I always describe this, I describe this in other videos this way, is that albumin is like the cool plasma protein. All the proteins and fluids and stuff want to hang out with it. So when it's in the bloodstream, when you have enough albumin, fluid stays where it's supposed to stay. But when your albumin's low, that's where you get that third spacing, where you get those people that have the ascites, their edematous and stuff like that. So, sometimes I'll recommend albumin if I have a patient who's really swollen and we're giving them diuretics, and then we can give them a diuretic and then give them albumin afterward, and it helps pull fluid where it's supposed to be. But otherwise, just because albumin's low, that maybe means that we need to look at this patient's nutrition. and then kind of see how we can help them. But if they also have a clinical picture that shows that they might be useful to, give them some diuresis and maybe some albumin, then I'll talk to a doctor about that. But just know that doctors will get fussy if you call them about albumin being low and ask for albumin. CO2. This one, it kind of depends. Sometimes we can use it. This is not accurate as an ABG because obviously this is a venous test where we're drawing blood from a venous source. But if there is extreme like metabolic issues with your bicarb and stuff like that, or you're having very severe metabolic issues, this can go very low or very high and kind of help us. So if this is abnormal, sometimes we'll look at it. We might get further tests like an ABG, a blood gas, or kind of check out the respiratory and kind of kidney metabolic state of the patient. It's kind of complicated, so I'm not going to go too deep into that, but I did want to introduce that. So coagulation test, there is PT-INR, APTT or PTT, and then there's some other things. You might hear different names depending on your facility. A viscoelastic profile, a TEG, that has a long name I can't say, or a Quantra. So um, a lot of these, you don't need to get all of these on every patient. A lot of times it depends on the patient. If the PTT-INR or APTT, PTT is elevated for any patient, it's higher than the normal number. It can be a sign of a coagulation issue, but we don't, again, need to get these on everybody, just depends on the patient. If a patient is on warfarin, we really want to get a PT-INR. And if they're on warfarin, the goal usually depends on the patient. The goal usually is for that PT-INR to be 2 to 3. When I say PT-INR, it's usually officially an INR that we're looking at. We want it to be 2 to 3. If they're not on anticoagulation, you can see the normal there about 0.8 to 1.2. Now, again, I can't look at for a patient that's on heparin and look at this number and tell how they're doing. So then there is the PTT or APTT, and this is all about a patient that's on heparin. And so, just as a reminder, this goes for INR and for PTT. What this is measuring is how many seconds or how long it's taking for blood to clot. So if this number is higher, that means I am taking longer to form a clot, which means I'm higher risk for bleeding. Whereas if this number is low, I'm forming clots right and left, and then I'm really high risk for clotting. So high, bleed to death, low, clot to death. So we like it kind of, we need to be forming clots on a regular basis, but not so much that we're clotting to death, but we need to be forming clots so that we're not bleeding to death. So this is kind of some general, some numbers that you might see. The main one, again, we look at this usually when they're on an anticoagulation. And when I say for PTT, APTT, this is when they're on a heparin drip. The subcutaneous, the stuff that we put into the tummy, the like prophylaxis, we do not need to check PTTs for that because we're not trying to get therapeutic for that. That's just a prophylaxis. But if someone has a blood clot, is on a heparin drip, had a heart attack, had a stroke, whatever it is, and they're on heparin drip, then usually we like their PTT to be around 70 to 90. We want it to be higher. We want them to take longer to form a clot because usually there's already a clot there and we're trying to prevent them from forming new clots. That's 9 times out of 10 when a patient's on warfarin or heparin, it's because they've been clotting or they're really high risk for forming a clot, and we're trying to prevent them from forming too many clots too fast because we're worried about a heart attack, or worried about a stroke or a DVT, etc. The viscoelastic, TEG, Quantra, these are all different tests, but they all kind of do similar things. And yeah, my husband's mowing outside, so if you hear, don't mind. Um, this is all about like how a patient is clotting in general. So these are great. We use these a lot on trauma patients, but they can use them on any patient who's maybe doing something weird with their clotting cascade or their coagulation. And it can kind of just tell us in general how they're doing with clotting. So what other blood products do they need? Because a lot of times these help guide us. Like, do they need plasma? Do they need cryo or other blood products? I'm not going to get deep into this. I can make a whole other video just on this test because it's a little more complicated. But this just kind of tells us how they're clotting in general. Cardiac labs, my favorite. So there's troponin, CKMB. These are your kind of heart attack labs. It's going to vary. There is 2 types of troponin tests, and there's also we call it the CKMB. It does vary and stuff a little bit. But as a whole, these should not be elevated. So if these are elevated, this is showing signs that a patient's heart has been damaged. Now, if a patient just received CPR, if they have chest trauma, if there's any sort of damage to their physical heart, or they have really bad cardiac disease, this can also be elevated. It's just about, kind of trending that. We also usually want to get other diagnostics like an EKG. We might get an echo and other things as well. Chest X-ray. We kind of trend everything as a whole. But if it's elevated, this is one that I want to call the doctor. So, BNP, BN as in Nancy, as I call it P, brain natriuretic peptide. This is a measure of how much fluid stretch is in the heart. In other words, it kind of measures effectively how much like pressure from fluid is around the heart. It should be less than 100. If it's elevated, it's usually a sign the patient either has heart failure or some sort of heart damage that's leading to um, issue with kind of fluid. And when I say fluid crowding their heart, I'm not talking about a pericardial effusion. Um, I'm talking about actually them having an issue where they might need something like a diuretic to help to decrease that fluid around their heart. It can also affect their breathing. A lot of times, patients that have a high BNP may be having trouble breathing, things like that as well. So, usually, these patients, the main treatment for a high BNP is going to be diuretics. And usually, if I have a patient who has a high BNP, I'm probably going to think to myself, if this patient's on IV fluids, do I want to ask if we want to stop those because it may be a little bit too much for their heart if their heart already has kind of this overload of fluid. Other things we might get are things like a lipid panel. And obviously, these numbers can vary, depends on the patient, but this can tell us a lot about how the patient's doing overall cardiac health. If your cholesterol gets high, you get blockages, you can have heart attacks. So, we definitely want to kind of keep an eye on this. If these numbers are off, this is more maintenance stuff. Sometimes we'll get them started on cholesterol medications, but it's a lot about diet, lifestyle changes, exercise, and those diet changes like a lower fat diet. So, looking for infection. This one probably most people don't know about. I didn't know about it when I was in nursing school. No one really told me about it. I think it's been more common since I've left nursing school. It's what's called a procalcitonin. And a procalcitonin effectively tells us how a patient is doing when it comes to like it's a very specific number. I'm not going to get into the science of it, but it tells us if it's elevated that there's most likely an acute infection. So, like the higher this number is the higher chance that there's an acute infection. This can be really useful because remember going back to what I said about the white blood cell count, sometimes it's hard to tell is there an infection or is there just inflammation? And sometimes we're doing cultures and everything's coming back negative. So we're like, is there an actual infection? So I see that we order this pretty regularly now to kind of see it's not perfect or perfectly accurate, but can be useful. Then one of the best things to truly see is there an infection is go to the source. We check their blood. Is there a organism or something growing in their blood? Is there anything in their sputum or their urine? That's usually the first thing you want to do. So when I look at a patient and I'm concerned about infection, I'm looking at them and I'm saying, okay, are they showing not just like, is there any reason for me to suspect that they would have a lung infection? Like, is their chest x-ray abnormal? Are they coughing a lot? Are they coughing stuff up? Is it an abnormal color? Are they running a fever? Stuff like that. If it's in their blood, they can be acting very strange, like a lower level of consciousness, maybe a little confused, delirious. They can be having a lower blood pressure, almost like signs of sepsis and stuff like that. In their urine, if it's an older patient, they can be having that, like, older people, when they get UTIs, they get very confused and things like that. So that can be a sign. If a patient was acting normal and suddenly now they're acting less normal. It could be a sign, especially in the older population, but then also tied with the actual culture, like what are the urinary symptoms the patient's having? Are they having frequency and urgency, like I have to go right now, and they're going more often? What does their urine look like? Does it look kind of cloudy? Things like that. And the only other thing I didn't mention here that you can do is, of course, like wound cultures, things like that. If the patient has any wounds, or when I were working in trauma, sometimes what we do is we have patients that have like orthopedic devices. Sometimes we need to have the orthopedic team come by and take those down and see if there's any wounds or infection underneath those like braces and devices. So for urinalysis, on the next slide, I'm pretty sure I have, what should be in it and what shouldn't be in it. So we'll talk about it there. Just know these are supposed to be clean or sterile. So if you're drawing them from a Foley catheter, make sure you're following the correct technique per your facility, and keeping things clean as possible. If not, if it's a clean catch, then make sure that you're doing and teaching a patient how to do that in a clean way and they're cleaning themselves prior. So we use a urinalysis for a variety of things. Sometimes, of course, nephrology uses them if there's like electrolyte or other like kidney issues. They might check like urine electrolytes, and things like that. But usually your urinalysis is used to see if there's some sort of infection or things in the urine that aren't supposed to be urine. This can be for kidney problems, or it can be for if there's an infection, or it can be if there's a concern for a problem in a different organ or trauma or other things. We can also use it for that as well. It kind of tells us a lot. And you can see here, this is what usually comes back on a urinalysis. There's the appearance, is the appearance normal, which would be like a clear? Oh, sorry, yeah, appearance, the normal is going to be clear, or is it cloudy? What's the color? Because the color can tell us a lot. If the urine is a strange color, then that tells us a lot. I had a patient the other day that was going into what's called rhabdomyolysis, which can happen after trauma where their tissue breaks down and their urine was just getting super cloudy, full of junk. And so, yeah, at the end of the day, it's, that just that alone can tell me a lot about how the patient's doing. Protein should not be present in the urine most of the time. If it is, then think kidney problems because usually the kidney filters protein. If it's not filtering protein, then there's a problem. Specific gravity, this is that annoying stuff that we looked at when we talked about the difference, like not thyroid, but like DI versus SiADH and stuff like that. But it can tell you a lot about how diluted or dehydrated the patient is. If the specific gravity is low, it means that you're more diluted. But if your specific gravity is high, then that means you're more dry or dehydrated. It's effectively measuring like what your particle to fluid ratio is in your urine. Bacteria obviously should not be present, hopefully. And so definitely want to be keeping an eye on that if it is. So a lot of times, at least at my hospital, when a urinalysis comes back positive for so many of these things and infection related, then they'll automatically reflex and do a culture on it. White blood cell count, sorry, not white blood cell count. White blood cells should not be present as well. Ketones should not be present or glucose. These are signs of, that's another reason, I guess, something I forgot to add is that it's something that we would maybe look at for, is the patient in a diabetic crisis or, their blood sugar is so high, like, because that's what happens is when your blood sugar gets so high that your body's like, okay, well, we need to get rid of this stuff. All right, pee it out. So this is kind of one of the things. That's why if there's anything that there's extra stuff in the urine, it's a sign your body's probably trying to get rid of it and you have too much somewhere else. You also should not have casts in your urine. Casts are actually breakdown of the kidney materials that's coming out, through your urine. This is not good because it usually means there's some sort of kidney damage or kidney issues. So you want to look at kidney function and stuff like that as well, or it can be signs of an infection. Um, Blood or red blood cells should not be present. That can be another sign of a UTI because it kind of there's irritation along your urinary tract during an infection that can lead to some blood coming out. Bilirubin should not be present. It's usually a sign of a liver or gallbladder problem. Nitrates and leukocyte esterase also should not be present. And those are also signs that when those are elevated, it's usually a sign of a UTI. Other labs, and for whatever reason, I feel like one day they just need to put these in the chemistry, but for some reason you have to order them separately from the chemistry. So mag and phos, magnesium causes more issues when it comes to the heart or cardiac activity. And one thing you want to consider is that if my magnesium is low, it's going to be, I can be chasing my potassium for days. But if I'm not replacing my magnesium first, my potassium is going to take forever or never fully come up. So always make sure if you're having a potassium low issue, check a magnesium as well. Make sure we're not chasing something that can't be caught. Just the way that they work. Um, and I haven't seen too many issues with a high magnesium except in patients that have renal dysfunction. Then phosphorus. This is more about the kidneys. It works opposite of calcium. If it's low, we replace it. If it's low, it's not one that you need to call the doctor 1 in the morning about and be like, oh my God, my phos is low. Unless it's like crazy low, like zero point 0.4, then sure, call. But usually this is one that can wait till the morning and get replaced. But we replace it. If it's high, it's usually a sign my kidneys aren't working. Then I have the thyroid panel here, the TSH, and then the T3, T4. And remember the difference here. The TSH is how much hormone that I have. If this is elevated, it's a sign that I'm low on thyroid hormones. Whereas oppositely, if my TSH is low, it's a sign that I have too much. In other words, my TSH is my stimulator. Think the S in the middle. This is my stimulator. So I am high because I'm stimulated because my body's like, I'm low, replace more. But the stimulator is low if I have an over abundance of thyroid, if I'm hyperthyroid. So we can look at TSH, but the better measure of how a patient's doing with their thyroid is going to be the actual hormones, which is T3 and T4. And this is deeper beyond my stretch as I am not a provider and not that smart, but here's some normal values. But usually if they're low, then we're going to give them, hormone replacement. If they're high, then we're going to do treatments for hyperthyroidism, which can vary depending on surgery, radiation treatments, and other things like that versus medications to bring those numbers down. But yeah, you always want to look at your patient. Remember, low thyroid, kind of slow, sluggish, high thyroid, they're like, fight or flight, going real fast. I like the very hot and where it's like cold is low, hot is high, things like that. But you can go back. I have a whole thyroid lecture on a different PowerPoint. Then inflammation, the main ones we look at are CRP and ESR. Here's the thing. These are great to say, hey, there's inflammation in the body, but that's literally all they say. They can't tell you where the inflammation is, how bad it is, what to do about it. So all I can say is, hey, there's inflammation. So we do order these, but it only tells us so much when it comes down to it. And you could be inflamed because of an infection. You can be inflamed because of chronic inflammation. You could have an autoimmune disorder. There's so many things. So that's why you need to do additional labs with this. This is my last slide, but I realized I did leave out the hemoglobin A1C. So, it varies kind of what, quote unquote, normal is. Most of the time, what I see is like 5.6, 5.7. Anything above that is considered abnormal for hemoglobin A1C. Keep in mind for hemoglobin A1C, this is a measure of how your glucose has been. How, like, pretty much I think of like how much extra glucose has been chilling on your hemoglobin for the past 3 months. So this is not a test that you can cheat, kind of like when you brush your teeth really well the week before you go to the dentist, hoping they don't notice that you haven't done a good job the last so many months. You can't cheat this test because this measures overall for 3 months, how has it been? Effectively, this kind of gives us an idea of overall how glucose health is. Now, you could look at this and be like, person's obviously not taking good care of their health. And it could be true. And often it is true. Sometimes, though, it's a sign that whatever medication they're on isn't working. And we need to look at their medications and assess, like, is it working? Sometimes it is lifestyle stuff. But it also could be a brand new diagnosis of diabetes too. So usually with the hemoglobin A1C, it's one measure we use along with others to kind of tell us how things are going. There's obviously a lot more labs than this. This is just a few, but these are some of the basics. Hopefully, something here was helpful to you. And yeah, I hope that I always enjoy sitting here and talking to you about science, medicine, nursing, and other things. So if there's anything else you'd like to learn more about, let me know. See you next time.